Hello, and welcome to the Osteogenesis Imperfecta Foundation's podcast series. On each podcast episode, the OI Foundation brings you information about the diagnosis and treatment of osteogenesis imperfecta presented by an expert in the field of OI and rare bone disease. The podcasts are a part of the ongoing educational effort of the Brittle Bone Disorders Consortium, part of the National Institutes of Health's Rare Diseases Clinical Research Network. Our podcast today will focus on rotting surgery in OI. We're very excited to hear from Dr. Maegen Wallace from Children's Hospital and Medical Center in Omaha, Nebraska.
My name is Maegen Wallace. I'm a pediatric orthopedic surgeon at Children's Hospital and Medical Center in Omaha, Nebraska. I've just been asked to talk about rotting surgeries in osteogenesis imperfecta. So I'm just going to give kind of some basic thoughts about rotting surgery and just some things that as orthopedists we think about when we're talking to patients about doing surgery. And then I have a few just examples at the end just to get an idea of what we're talking about. So I think the biggest thing to know is that from an orthopedic standpoint, not all patients with OI are the same, which I think those of us in the OI community understand that. But also every patient who has type 3 or every patient who has type 4, they're not the same. Their bones are different, and everyone has different needs in terms of what their function is and what problem areas they're having or what their goals are. And so all those things need to be taken into account. In the patients that have more severe forms of OI, they tend to have more bowing and more deformity. And so those are the patients that we tend to talk about doing different rotting surgeries earlier in life. And the most common reason to do a rotting surgery early in life is if there's significant deformity and we're concerned about fractures, or if a patient has sustained a long bone fracture that's unstable, then that's a good reason to consider doing some sort of surgery on that as well. One thing to know in OI, we really try and stay away from doing plates and screws and try and do more types of fixation that goes inside the bone to protect the entire bone. When we have plates and screws, we end up with stress risers at the end of the plate or at one of the screws, and that increases your chance of having more fractures at that location, and can also develop deformity next to that as well. And so most of the time we talk about doing intramedullary devices, and that's your best option if you can. Not every fracture can take an intramedullary device, but if we can, that's what our goal is. I think our goal with any kind of surgery is to decrease at least the severity and hopefully the frequency of fractures. And also, we know that sometimes fractures are inevitable, and so if we can decrease the amount of pain that you have associated with a fracture, that's also important, which if you have an intramedullary device in place, that oftentimes decreases the amount of pain that you have associated with a fracture. We also want to increase patients' mobility by improving their alignment and having them be able to move easier. The type of rod that we use depends on several different factors, and you'll hear about growing rods or rods that elongate with patients as they grow, and then we also have different options that don't elongate. So in terms of age, the younger the patient, and if your growth plates are open, that's when we consider doing some sort of rod that elongates. The most common that we tend to use in the United States are the Fassier-Duval rods or the FD rods. And depending on your orthopedic surgeon and where you're at around the country, different people have different thoughts on when to do your first surgeries. We tend to think that once patients are starting to pull to a stand and showing interest in walking, if they have a large enough deformity, they're likely going to break. And so those are the patients that we talk about doing surgery prophylactically. And depending on the patient, sometimes that's at 12 months, sometimes it's at 24 months, sometimes it's even at 3 years of age. So it just depends on every patient's an individual, and every patient's a little different. But we know, especially with the femurs, that if you have more than about 20 to 30 degrees of bowing of the femur, it's likely going to break again. And most of the time the femurs bow in a kind of anterolateral location. Not all the time, but that tends to be pretty frequent. The tibias also tend to have a lot of anterior bowing. And then we also see bowing in the upper extremities, in the humerus and in the forearm as well. In terms of timing and when we do surgery, some of that depends on the number of fractures patients are having and how severe their fractures are. Sometimes if the fractures are non-displaced or incomplete fractures in the patients that are younger, we can treat those conservatively without surgery. But we know that the more deformity you have, the more likely you're going to have more fractures. And we also know that if you're getting into a fracture cycle where you don't have rods in place, that can also increase the frequency of the fractures that you have, and so that's also another reason to consider rodding surgery. Another common thing that people talk about is how many bones to rod in one setting, and that's also very surgeon dependent and kind of site dependent. So a lot of it depends on the patient's ages as well. So some centers will do one limb at a time, so one femur and tibia on one side. Some places will do just femurs. Sometimes we'll do all 4 bones, femurs and tibias in one setting. All of that just depends on the patient, where their fractures have been, what their deformities have been. And some of it also depends on how long surgery is, how long the patient's under anesthesia, and how much blood loss you're having. So just pushing through if we're losing a lot of blood always isn't it the best option as well. The more bones that you do, the greater chance you have of needing to have a blood transfusion as well. So those are all things that we take into consideration in deciding which bones to do, how many to do at one time, and those kinds of things. The other thing to think about sometimes in our patients that are more severe, that are not pulling to a stand and walking, but are just having trouble with sitting up, or having recurrent fractures in their arms because they're using their arms to try and help balance themselves when they're sitting. Sometimes doing upper extremity surgeries, even before lower extremity surgeries. So sometimes if the humerus is bowed significantly, every time a patient's trying to sit and tripod and hold themselves up, if they start to topple over, they'll try and catch themselves with their arm and can develop deformities and multiple fractures of the humerus. And so sometimes doing humerus surgery first is the best option for some patients. The other thing to consider is anesthesia and pain considerations. So we tend to do some epidural anesthesia to help with pain control after surgery when we do our lower extremity surgeries, and that works very nicely for our patients. So that's another thing just to consider, because we know that surgery hurts. We also know that we want to try and do the least number of surgeries as we can, but also do everything as safe as we can as well. Within the surgeries themselves, every patient's different depending on where their deformity is. We try and do the least number of incisions as we can, but also be able to get the bones straight. So we know we have to make at least one incision to put the rod in. Sometimes if there's been a fracture recently, sometimes we can actually just straighten the bone out and put the rod in safely and not have to make other incisions. Other times we have to make small incisions just to do a small osteotomy to straighten out the bone. And then still other times we have to make bigger incisions to be able to take more of a bigger wedge of bone out to be able to correct the deformity depending on where the deformity is and how big the deformity is. And then another thing to consider after surgery is what type of immobilization we use. So again, depending on your surgeon, everyone is different. we tend to do splints for our immobilization after surgery. We find this is nice because they can be removed. We can monitor skin to make sure pressure sores aren't developing, and also keep the patients a little bit more mobile than doing your classic hip spica cast for, say, a femur surgery, for example. We tend to do immobilization for about a month. Usually about a month after surgery, there's some good early healing where the patients are pretty comfortable and not needing to have the immobilization anymore. One other thing is, we know that patients that have surgery and have rods put in, it's not uncommon to need to have those revised at some point. Depending on the reasons for revision, sometimes those can be straightforward if we're just needing to switch a rod out to put a larger rod in. Other times they can be more complex, and every revision is different, and so that's a case-by-case discussion to have with your surgeon. But there are a wide range of complications that can happen from rod surgeries. One thing that can happen, especially when the bone is really soft, is the rods can back out. If that happens, depending on when it happens after surgery and why it happens, sometimes it's a reasonably simple fix of just putting the rod back in. Other times it's needing to revise the entire rod. It just depends on why the rod is backing out. Sometimes as the children grow and the rods are elongating, you can get bending of the rod even without a fracture, and then if you have a fracture, sometimes the rods will bend because of the fracture as well. So that can be another reason to need a revision. Sometimes once the rod bends, sometimes the nails will no longer telescope. And just because a rod doesn't telescope doesn't mean that it automatically needs to be revised, but that is one reason why we tend to see some revisions that need to be done. Some other complications that can occur, you can have infections. That's pretty rare, but it can happen. And then another thing that can happen is a non-union where the fracture or the osteotomy doesn't heal. In the literature, that tends to be around 15% of patients on X-ray will have a non-union, but not every patient that doesn't have complete union on X-ray has symptoms. And so that's one thing that we're looking into with our research a little bit more is which patients are symptomatic from their non-unions and how best to treat those. Depending on the series in the literature you look at, the time to revision for different surgeries for femurs and tibias, in our series, the average time to revision was a little over 4 years. And seems to be in most of the literature that's kind of the average time to needing to have a rod revised. I do have a few cases that just kind of highlight some of these things that I just talked about. The first slide here shows a little 2-year-old girl who has type 3 OI. And she was starting to get interested in pulling up to a stand, and so we had talked to her family about doing rodding surgeries of her femurs and tibias. And so you can see the bowing that she had before surgery and then how straight her legs are after surgery. This is a pretty typical patient with type 3 that has all 4 bones done in one setting. The next slide actually shows how all 4 bones can safely be done, even in a patient who's older. So this is an 8-year-old girl with type 4 OI, and the first set of images you can see her significant deformity, and then the second set of x-rays with the rods in are just a few months after her surgery, and then the next set is a whole year after her surgery. So you can see how she's grown significantly and how her deformities are nice and straightened out, and she's healing everything nicely. The next slide is also a patient with type 4. You can see first x-ray is when this patient was within the first year of life, so you can see the bowing present, and especially in the left femur and both tibias. And then the interesting thing is the follow-up x-ray here is when the patient's 8 years old. And you can see how just because a rod no longer telescopes, you can see that little rod within the tibia, doesn't mean that the rod didn't need to be revised. So that patient hasn't had any troubles with that tibia and hasn't had any bowing once the leg was straightened out at a young age. And then you can also see how much the rod in the femur has telescoped and is doing really well at that point. Just a few more examples. So the next one is a 14-month-old who has type 4 OI, who had just the femurs rotted because this patient didn't have any significant bowing in the tibias and hadn't had any troubles with those. This patient's femurs were able to be done just with one incision to put the rods in, and then was able to just be straightened out without making additional incisions. And then you can see that first surgery was done at 14 months of age, and then you can see when the patient was over 2.5, had sustained a fracture of the left femur, and that rod had bent, and then the revision surgery was just where the old rod was taken out and a new rod was put in, and the fracture was able to be treated in that way without having to make any open incisions. The next patient is actually, or the next pictures are actually the same patient, just shows some images of a humerus. So you can see the significant deformity that he had in his humerus. That we do have some rods that are not growing or elongating rods that sometimes we use because they're smaller in diameter when a patient is very small. And so you can see the first set of x-rays on the top right where that rod was placed. No incision was made down where the deformity was. That was able to be straightened out manually. But that rod is a non-elongating rod. And then you can see as the patient grew, the rod actually started to migrate out, which is not uncommon. And you can see that he was starting to develop some deformity at the distal part of the rod near the elbow joint. And so then we were able to actually straighten this out and then put a growing rod in now that the patient is older. And then the next one is just an example, again, of showing a patient with type 3 that had a humerus deformity that had a non-elongating rod put in when he was 3 years of age. And then you can see at 11 years of age, he hasn't had any troubles with that humerus. That rod is small there, just sitting inside his bone, and he's not had any other issues with that. So just because you have one surgery doesn't mean you have to have it done again, which sometimes will occur. And then the last example is just a forearm example. So we can't use growing rods in the forearm because the bones are so small, but you can see this patient with a significant bowing deformity of the forearm. The surgery was done when they were 3.5 years old, and you can see the nice correction and how straight it was on the top right picture, and then the bottom left you can see how that patient has grown, where those wires are obviously can't grow with them, and so they developed a fracture and some deformity at the end of one of the wires. And then the bottom right picture is a revision, taking the old wires out and putting new ones in, and protecting that area while it's healing. So just some general overview of rotting surgery. Again, every bone is different, every patient is different, but there are lots of options, and our goal is to try and protect the entire bone with rods that go inside the bone, and hopefully be able to get a rod that grows with patients to try and decrease the number of times they need to have their surgeries redone.
Thank you for joining us on the OIF podcast, Dr. Wallace. Listeners, for all OIF podcast episodes, visit www.oif.org/OIF podcast. Stay tuned for the next episode.